Hi there, this is my EJV video. Okay, today I'm going to be demonstrating how to place a EJV or external jugular vein line. Okay, this is indicated for patients with difficult vascular access, both peripherally and medially. Patients that require pain relief or medication can be given this to provide them with the required substance or dose for the required outcome. Okay, I've got my pre-drawn up sodium chloride, which has been drug checked by my outsider. For the purposes of this demonstration, I will be using a 20 gauge needle as I don't want to damage the mannequin. However, in reality I will be using an 18 gauge needle as is preferred. Okay, I've got my 20 gauge needle with a pre-drug checked sodium chloride to check my flush. I've got my lure plug. I've got my alcohol prep pad, my Tegaderm, and my gauze, and then also my sharps container. Okay. First and foremost, gaining consent with the patient, explaining the outcome, also what's required of the patient. In this case, my patient is going to be unconscious. Okay. You're then going to rotate the head to a position that you can visualise the external jugular vein. In some patients this will be difficult, and there are methods that can be done to improve the visuality of the external jugular vein, such as asking the patient if they are conscious to bear down, being able to do a supraclavicular tamponade. This will increase the visuality of the jugular vein, and also hepatocyte pressure or pushing on the liver. Okay, so I've visualised my EJV, I've explained and gained consent with my patient. I'm going to pull out my 20 gauge needle. Okay, keeping with sharps etiquette, I'm going to open it, sharps out. I'm going to do a supraclavicular tamponade, and tamponade the top end, tamponade and hold. Then what I'm going to do is approach on a 15-degree angle, making sure to stay as hygienic as possible. This also prevents the risk of air embolus, plastic embolus, or pneumothorax. Okay, so I've sighted the area that I need. Okay, going to inform the patient sharp scratch. Okay, I have flashback. Going to lower the catheter, lower the needle, and approach by 2 to 3 millimeters. I'm then going to put negative pressure on my syringe and draw back. I can confirm I have flashback. I'm then going to advance my plastic catheter, like so. Removing my needle, placing a sharps container. Then going to put my lure plug on the patient. Okay. I'm then going to tape it. I'm then going to grab my sodium chloride, which has been pre-checked by my offsider, to make sure it's the correct dose and drug. In this case it's sodium chloride. Okay. Then going to place this on the line, and I'm going to flush to check that I've got a secure and patent line. I'm going to give 5 mils. Given. I'm then going to secure my EJV. A couple of concerns that have to be taken into account, of course, is the risk of pneumothorax by puncturing the thoracic cavity, which has to be minimised and observed, as we don't want this to happen. Also the risk of air or plastic emboli. There's also an increased risk, however, that was the reasoning behind my supraclavicular tamponade and tamponading and above the site also. Okay, I'm then going to secure my lure again. This is now accessible for medication for the patient. I'm also going to date and time as well as the location and supplies of the needle. I'm going to place it for hospital staff and future pre-hospital staff to know the location of the EJV.